So welcome to this webinar on extracellular matrix and autoimmunity. So my name is Signe Holm Nielsen, and I am very excited to be moderating this webinar today on behalf of the Extracellular Matrix Pharmacology Congress and these webinar series. So today's topic is breaking down the matrix, the interplay between fibrosis, inflammation, and autoimmunity. And before I start introducing our great lineup of speakers, I would like to briefly highlight that we are having the Extracellular Matrix Pharmacology Congress, the biannual meeting in Copenhagen in June 2026. So I hope to see many of you come and enjoy this wonderful city in June. So we have very few housekeeping rules for the webinar today, but if you have any questions during the talks, you can ask those either the private, public, or Q&A chat function you can find on your screen. And after the three presentations, we're going to go through the different questions and have a little bit of a discussion. So let's get started with today's program. So the first speaker of today is Professor and Dr. Dinesh Khanna. So Dr. Khanna doesn't really need much introduction for us working in scleroderma, but Dr. Khanna is really a leading expert in systemic sclerosis, scleroderma, and related conditions. I think you have probably hit around 500 publications and 70,000 citations at this point. So he's really directing like a multidisciplinary team of clinicians, scientists, and researchers that are really trying to understand scleroderma. So Dr. Khanna is really looking into how he can improve the life of patients while trying to figure out the pathology and trying to set up clinical trials and really understand the new and upcoming treatments. So today, Dr. Khanna will give us a talk on systemic sclerosis and the vascular inflammatory fibrotic axis. So Dr. Khanna, I'll give the stage to you, and I look very much forward to hearing your talk.
Thank you very much, and good morning, everybody. Good afternoon, everybody. Dr. Kallenberg and I are sitting in Ann Arbor, Michigan on Eastern Standard Time. So hope you can see my slides, and I'm delighted to present, the story of systemic sclerosis, the interplay, the delicate interplay between fibrosis, inflammation, and autoimmunity. Here are my appropriate disclosures. I work with many pharmaceutical companies, NIH and FDA, trying to make the lives of scleroderma better. And here are the objectives of the talk. There are 4 objectives that I would like to cover in the next 20 to 25 minutes. The first one is just to highlight the very high unmet need in people with systemic sclerosis, also known as scleroderma. Discuss a little bit of work we have been doing to understand the interplay between vasculopathy, inflammation, and fibrosis. Discuss how we are targeting systemic sclerosis with novel therapeutics, and end with role of collagen biomarkers as a prognosticating and a pharmacodynamic markers in this disease. So it's always good to introduce a disease. It's an orphan disease, and scleroderma is a group of disorders meaning hard skin. It's a Greek word, scleroderma. There are approximately 200,000 people in US who suffer from systemic scleroderma, and approximately 75 to 80,000 of them have systemic sclerosis. So systemic sclerosis is part of disorders what we term as scleroderma, and it is indeed an orphan disease. Like lupus, which we'll hear from Professor Michelle Kallenberg, the peak age is 30 to 50 years. There's a female predominance of 5 to 1. It is quite a heterogeneous disease. And I think one thing that every rheumatologist would agree is that it has the highest mortality and the highest unmet need of any rheumatic diseases that we treat. Below, I give you some estimates of incidence and prevalence. Suffice to say, it's an orphan disease when you look from a regular perspective, whether you look at the FDA, EMA, or other health authorities. Here's a slide on different phases of systemic sclerosis. This is a presentation and publication set approximately 9 years ago with Professor Denton. And I just want to highlight that it is not just skin deep. On the top, I'm showing you 2 patients who have significant skin fibrosis with skin involvement of the face and hand contractures. The left panel is showing you Raynaud's, digital, vascular abnormalities, telangiectasias on the face, and calcinosis. And the right lower panel is showing you what can happen with digital ulcers with amputation and internal organ involvement. Highly heterogeneous multi-system disease can affect heart, lung, kidneys, gut, musculoskeletal involvement, and can have a profound effect on quality of life, high morbidity, and a very high mortality. I'm going to introduce some terminology that we use in scleroderma or systemic sclerosis world, and it's important to understand that there are two large subsets that we talk about. The first one is a diffcutaneous subset. This is where the skin rapidly progresses over the first 3 to 5 years and softens. And this has been the most difficult situation when people talk about regulatory approval, because skin starts to heal naturally. Why does it do that? Nobody really knows. There's quite a bit of work happening with the omics right now to understand why does skin starts to heal. But early on is a time when people get heart, lung, kidney, gut, and other organ involvement, the exception being pulmonary arterial hypertension, which is a late complication. And then you have the limited cutaneous scleroderma. It is not limited to skin only. Limited cutaneous means that you have a little bit of skin thickening on the distal aspects of your extremities, but they still have heart, lung, kidney, gut involvement early on with pulmonary arterial hypertension and relationship to biliary cirrhosis as being the key leading causes of mortality later in the disease. So let's talk a little bit about pathogenesis of systemic sclerosis. This is a slide from Professor Varga and colleagues and the textbook on systemic sclerosis. And it's a very fascinating disease because majority, if not all, the patients start with vascular manifestation, i.e. Raynaud's phenomenon. Some patients have Raynaud's phenomenon for decades and years before they start to develop other symptoms and signs of systemic sclerosis, and some have abrupt onset of Raynaud's, internal organ involvement, and autoimmunity simultaneously. Why? We don't know. I'll share a slide on the hypothesis with endothelial dysfunction, but we really don't know why certain patients have long-standing Raynaud's phenomenon and slowly evolve, and some people have abrupt onset. There's indeed autoimmunity and autoinflammation. With autoantibodies, there are clear susceptibility genes based on the GWAS work, and resulting fibrosis in the heart, lung, kidney, skin, and other organs that I mentioned with extracellular matrix deposition. So here's a much more expanded version of what I just stated. And usually our thinking and others' thinking is that it is endothelial dysfunction right now with reactive oxygen species overactivity, occlusive vasculopathy. Our data that we published in JXMed shows that these are related to cytotoxic CD4 and CD8 cells. Others have shown that there is reactive oxygen species overactivity with endothelin-1 and Wall-Willebrand factor overactivation. Whatever it may be, there's apoptosis of endothelial cells. There is activation of both innate and adaptive immune system. Type 1 interferon signature is seen in about 40 to 50% of patients in early systemic sclerosis, and there's an ongoing trial of anifrolumab, which type 1 interferon receptor inhibitor right now. Most of the work and the focus has been on the activation of the T and B cells adaptive immune system with scleroderma-specific targeting autoantibodies that are largely mutually exclusive. Interleukin-6, which we have worked quite a bit on, both pro-inflammatory and pro-fibrotic cytokine, and different pathways leading to fibroblast to myofibroblast transition. I also want to highlight, like other fibrotic diseases, it's not just the fibroblast that is getting transitioned to myofibroblast. You have epithelial and endothelial to mesenchymal transition and other cells that are highlighted out here. The other key aspect, what differentiates systemic sclerosis, especially early from idiopathic pulmonary fibrosis, pulmonary arterial hypertension, kidney fibrosis, is this clear interplay between fibrosis and inflammation. On the left is a patient of mine who had a punch biopsy over the involved area on the forearm. You see epidermal hyperplasia, hyalinized collagen and increased extracellular matrix deposition, but also perivascular inflammation that is very clear in majority of the patients with early systemic sclerosis. And there are clear evidence of activated T and B cells, and it is also shown on bulk RNA-seq on the right. You're looking at 3 plots with early diffuse cutaneous scleroderma with involved skin biopsy with a disease duration of 1 year, and late scleroderma with 5 to 6 years of disease onset. And what you see is if you look at the CD4 T cell signature, CD8 and B cell signature, they are seen anywhere from 60 to 69% of patients with early diffuse scleroderma and only 18 to 20% of the patients with late systemic sclerosis. So as we evolve, as we talk about the management and treatment of systemic sclerosis, the role of immunomodulatory therapy, the CAR-T therapies and others become very important and critical. Continuing with the theme, I want to move from bulk RNA-seq to single-cell RNA. This is a work with Dr. Johan Gudjonsson and Dr. Michelle Kallenberg and others at University of Michigan. And we have been very interested in fibroblast and endothelial biology, and again, the interplay between fibroblast and endothelial biology. And this is based on 22 scleroderma patients, early diffuse, and 18 healthy controls with a total cells of approximately 96,000. 7 different subclusters that I'm showing you on the upper panel. And what is really fascinating, just on a visual appreciation, is this transition from the normal healthy fibroblast to scleroderma fibroblast. And these are SFRP2 fibroblasts in healthy volunteers and in scleroderma that have a transition to myofibroblast. Bob Lafiatas and others have published that these are the fibroblasts that transition to myofibroblast. When you look at the extracellular matrix score, that is from the Geontology website, which is a score made by averaging the expression of gene list in each cell and subtracting it by randomly selected control genes, you can see that SFRP2, COL8A1, and CCL18 and others have a very high extracellular matrix score. This slide is again continuing with the theme that you are making more myofibroblast, taglin gene, and the COL8A1 as you go from the healthy normal SFRP2 to scleroderma SFRP2 to taglin, and also contributing to extracellular matrix score, TGF beta score, CTGF, and other genes that are shown out here. And this slide, the next panel here on the lower slide is showing you the spatial seq on 2 patients. When you look at the extracellular matrix score, you can see it is distributed throughout the dermis, from upper dermis, superficial dermis to deep dermis. The collagen COL1A1 gene is usually in the deeper dermis, SFRP2 in the upper, and COL8A1 or myofibroblast in the lower dermis. Just to highlight the distribution and different components that are contributing to the extracellular matrix score. In the same study, we looked at the endothelial to mesenchymal transition, and there are 6 different subclusters that we have accounted for. The one that we have focused on is the arteriolar, and the reason being the juxtaposition of the first 3 clusters out here. But the subcluster 2 is the one that is really making a lot of extracellular, or has a very high extracellular matrix score. And if you look at the second slide here, this is the one that is really producing ACTA2, or the myofibroblast, and it is corroborated or confirmed by the genes shown by COL8A1, ACTA2, and taglin. So all the work that has gone here and that has led to some discoveries on the Hippo pathway, but really this slide is showing the interaction, like ligand receptor interaction in systemic sclerosis and how they're overexpressed compared to healthy volunteers. And most of the interactions, active interactions, are happening between endothelial, EC2, which is endothelial to mesenchymal cell subcluster, and myofibroblast, but active interactions happening between different cells, including myeloid cells. All this data is to highlight that systemic sclerosis is not a simple fibrotic disease. This is not idiopathic pulmonary fibrosis. It is not single organ. Early on, there's an active interactions that are happening between different subsets, and that's why targeting with cellular therapy and other targets may be effective compared to just using an anti-fibrotic therapy. So how do we treat systemic sclerosis in 2025? I must say that it's much more reactive. There are 5 different patients that are highlighted out here. Patient number 1 has Raynaud's phenomenon, where we use vasodilator. Patient number 2 has digital ulcers. We tend to use quite a bit of vasodilator. Patient number 3 and patient number 4 and 5 have significant skin and lung fibrosis. Treatment tends to be immunosuppressive, immunomodulatory therapies, stem cell transplantation, antifibrotics, and if they don't respond to the initial therapies, we tend to have these people participate in novel clinical trials, which I'll show you in the next slide. So here is that cartoon again, and the medications that we are utilizing. And if you look at the medications, and I'm sure Dr. Kallenberg may share her work and the pathogenesis of systemic sclerosis, mycophenolate is the go-to medication, but you can look at the pleiotropic effect on different immune cells when you look at mycophenolate. It's not a targeted therapy, and it has some modest beneficial effect, especially in patients who have inflammatory gene signature that is driven by the innate and adaptive immune signatures. We have nintedanib that's FDA approved. It's not just an antifibrotic, it's a tyrosine kinase inhibitor targeting VEGF, PDGF, and FGF. And then you have rituximab and tocilizumab targeting B cell biology and interleukin-6 biology. So these are the different medications. I just wanted to give you a snapshot of the clinical trials that are going on. On the right side is where most of the action is right now. That is really targeting either B cell biology, directly targeting through T cell engagers, or through CAR T therapy, or targeting the co-stimulatory pathway that leads to the activation of B cells. Of course, as I mentioned before, there's targeting of anifrolumab, a drug called avelciguat. If you really believe that endothelial dysfunction is the key driver of systemic sclerosis and fibrosis in the background of immunosuppressive therapy, this is a soluble guanylate cyclase activator that promotes a cyclic GMP, which is a second messenger, and is an important aspect of smooth muscle relaxation and endothelial biology, but it's also a very potent antifibrotic agent. So there are different pathways that are being targeted. And another one that should be FDA approved soon is a drug called nerandomilast, which is PD4B inhibitor, and had positive trials both in idiopathic pulmonary fibrosis and in progressive pulmonary fibrosis, including autoimmune interstitial lung disease. So there's quite a bit happening, because we are understanding the pathobiology. I also want to make a statement that animal models are notoriously have been poor. They lack sensitivity and specificity, and that's why most of us are really using skin tissues from patients with scleroderma to understand the pathobiology, but also pharmacodynamic and targeted effects of these novel therapies. So some of these slides have been provided by Nordic Biosciences, and it has been fascinating to see this evolution of these 28 collagens, like our colleagues Morten and other in their lectures provided. And one thing that is very fascinating, if you look from epithelial cell to interstitial matrix, there are 28 different collagens, and they have different distribution. As an example, collagen 4 is in the basement membrane, providing stability between epidermis and dermis, whereas collagen 1 and 3 are the most abundant collagen in the skin, lung, and other organs that are more in the interstitial matrix and may contribute to fibroblast production and the collagen production. Now, this is one of the slides how we think about the extracellular matrix. Healthy tissue, there's a good equilibrium between the production and degradation. In inflammation, what our Nordic Biosciences and other colleagues have shown is there's more extracellular matrix degradation, and in fibrosis, there's much more extracellular matrix formation as release of these protein fragments or neoepitopes into the blood. So think about systemic sclerosis, there's definitely an increased extracellular matrix deposition. There's no doubt. You can look at this slide and you can see this dense extracellular matrix deposition, but also remember there is scattered inflammation throughout the tissue, especially around the perivascular aspect of the disease. So let's look at some of the data. So this is slide number one. Here, what you are seeing is an extracellular matrix formation in patients who have early systemic sclerosis. This is a cohort from Pittsburgh, where they looked at very early disease with 1 year of disease duration versus 13 years of disease duration. And this slide should have had another photograph here, but shows extracellular matrix formation of the pro-C3, which was much higher in patients who had early systemic sclerosis versus late systemic sclerosis. And the same pattern you see in pro-C6, much higher production of extracellular matrix or production of pro-C6 compared to late diffuse scleroderma. One thing that is fascinating, if we really believe that it's only extracellular or matrix production, here you're looking at the degradation of type 3 and type 6 collagen. So you're looking at the degradation, and you also see the body is trying to evolve and increase the degradation, so there is an equilibrium that happens in these patients. When you look at the late diffuse patients or late disease, there seems to be an equipoise equilibrium between the production and the degradation of pro-C6 collagen production and degradation. Another way to look at this would be a fibrotic index. So it's an equilibrium between the production and degradation. And here you see the pro-C3 and C3M. And in this slide, I'm showing you the skin score evolution from mild, moderate to severe. They reach a peak and they start to improve. And there is really a relationship or an association of this production and degradation index, what we are calling, or the fibrotic index, that mirrors and could be utilized as part of following the patient for prognostic purposes and pharmacodynamic effect of the therapies. Another thing that we would like to do with these collagen biomarkers, I suppose, is to predict progression. Who are the patients who will have more progressive phenotype? And here I show you the data from Oliver Distler and his colleagues, published in Lancet Rheumatology. Very nice study where they took patients with systemic sclerosis and defined them as progressors or stable. Majority of the patients here had progressive disease with early systemic sclerosis, and the progression was defined by greater than 10% decrease in lung function or a skin score worsening of 25% and 5 units. And in this study, they again defined the fibrotic index. And this is very interesting data in patients who are healthy controls compared to patients with early disease, and they tend to be stable over the next 1 year. The fibrotic index was no difference between control and stable patients, but in patients who were indeed progressor, there was a clearly higher production of pro-collagen or type 3 collagen compared to degradation. So this is, again, an index that can be utilized to predict, maybe in clinical trials, maybe in clinical practice, who are likely going to be progressive patients versus patients who are stable over time. What about the pharmacodynamic effect? Can these markers be utilized to capture the pharmacodynamic effect of clinical trials or different therapeutic agents? The first example comes from tocilizumab story. This is a phase 3 trial, double-blind, placebo-controlled randomized trial, where the patients were randomized to tocilizumab, which is interleukin-6 receptor antagonist, or placebo. And these patients were chosen because they had very early disease with elevated acute phase reactants. They were randomized 1-to-1 to tocilizumab or placebo and followed for 1 year. The data showed no big impact on skin score, which was a primary endpoint because of the normal resolution of skin. But when you looked at patients who had lung fibrosis, the leading cause of mortality, there was stabilization of forced vital capacity in red in patients who were treated with tocilizumab, and a very large clinically meaningful decline in patients who were on placebo. In fact, if you look at the data from a clinician or a patient standpoint, annual decline in forced vital capacity is approximately 25 ml. So we lose approximately 25 to 30 ml in forced vital capacity in absolute quantity every year. And in this trial, over 1 year period, the patient lost 250 ml, 10 times the decline. The work that we have been doing in this area, this is the data from phase 2 trial that was published in Lancet a few years ago, the trial that I led. And I want to highlight, just to highlight as I talk about the collagen byproducts and the biomarkers, we wanted to understand how does tocilizumab work. We saw this very large effect on lung function that was a bit surprising. This was not the expectation in phase 2. And this is looking at the nanotechnology, bulk RNA. And what I show out here on the top row is healthy volunteers. The second row are patients who are treated with placebo at baseline. The third row are the patients with placebo at week 24. These are all skin tissue biopsies. So this is not in the blood. This is in the involved skin tissue biopsy. Fourth row are the tocilizumab patients on baseline. And the last row are the patients of tocilizumab at week 24. So when you look at the TGF-beta pathway, there seems to be some effect, but nothing that stands out. You also see some resolution in TGF-beta 1 in the placebo and in the patients on tocilizumab. The thing that really stands out is the modulation of macrophage biology, especially M2 macrophages, as clearly shown in the last row compared to the third row, which are the placebo patients at week 24. There seems to be some effect on STAT3 pathway, but largely the effect was through the macrophage biology. So here's another paper that came out of this study that has been worked with our colleagues at Genentech. We looked at 6 different pathways: inflammation, macrophage-driven markers, TGF-beta markers, periostin and COM, alveolar epithelial injury, SPD, collagen formation, pro-C3 and pro-C4, and C3M and C4M as markers of collagen degradation. So let's go over this data. Slide 1 or the panel 1, when you give somebody tocilizumab shown in orange, there's a paradoxical increase in interleukin-6 because you're targeting the receptor. There's a big impact on inflammation as measured by CRP and CRPM, and also a big modulation targeting the macrophage biology CCL18, YKL40. No real impact on COMP and maybe some impact on periostin, highlighting that tocilizumab have an effect that is independent of the TGF-beta biology. A big decrease or decline in C3M, C4M, highlighting that there is maybe the tocilizumab is modulating the destruction that is happening at the collagen level, decreasing the degradation, but no effect on pro-collagen 3. Another fascinating aspect out here is to looking at the prognostic biomarkers. So there are 4 markers that stood out: interleukin-6, the marker of inflammation, COMP and periostin really stood out with the R square out here. The higher the periostin, the higher the COMP levels in the serum at baseline, the more progressive phenotype the patients will have. And then the other one that stood out was a TGF-beta biology, maybe pro-C3. So there are 3 different TGF-beta biologies and the collagen byproducts that stood out for a more progressive phenotype that could be used as enrichment predictive biomarkers. So how do we think that, if I have to summarize everything, how do we think that tocilizumab really works? I think the treatment on the left slide, the treatment of tocilizumab does not change ongoing epithelial damage. There's no change in the SPD, but instead reduces inflammation induced by activated macrophages. You're seeing a reduction in CRP, CCL80, YLK40, which in turn may reduce fibroblast activation. It seems to spare the TGF-beta pathway, no modulation of COMP, periostin, pro-C3, but there was a very large clinical benefit that we have not seen before, highlighting that in patients who are enriched for active inflammatory disease, the pathway is really driven through the macrophage biology early on and not a typical fibrotic pathway. On the right is a scleroderma skin, where the modulation is happening in the macrophages to reduce the macrophage activation. Again, serum CRP, CCL18, YKL40, but the TGF-beta involvement remains and contributes maybe to the lack of efficacy we saw with tocilizumab on the skin biology. Another trial that we looked at is a drug which is an autotaxin inhibitor with Galapagos. The study again shows on the panel that I'm highlighting the challenge of using skin score as a primary endpoint, the modulation and the improvement that happened, much higher in the autotaxin inhibitor compared to placebo. But when you look at the biology, how is autotaxin inhibitor really helping? It is really reducing the extracellular matrix degradation biomarkers. It really did not have much effect on the production biomarkers. Some of them, you can see that there's a reduction in all the degradation biomarkers. So with this, I would like to conclude, and I think I didn't slide to my colleagues here, and this is my last slide, that systemic sclerosis is a heterogeneous disease with variable organ involvement and highest mortality of any rheumatic disease. I think when you talk to rheumatologists, if they had to pick up one disease, systemic sclerosis followed by maybe lupus nephritis are the two top disorders or diseases where we would want to find effective therapies. There's an increase and greater understanding on the interplay between different pathogenetic pathways in systemic sclerosis. Current therapeutics are targeting novel pathways in background of immunosuppressive therapy. And I just want to highlight the role of collagen neoepitopes as prognosticating biomarkers, as pharmacodynamic biomarkers that can be utilized to understand the mechanism of actions of novel agents. Thank you very much.
Thank you very much, Dr. Khanna, for a very inspiring and good talk. So I think we can all agree there is still some way to go, and I can see questions are coming in, a lot on biomarkers and ILD and so on. So we'll take that in the end. So remember, you can always ask questions in the Q&A and in the different chat functions. So let's move on to the next speaker. So the second speaker of today is Professor and Dr. Michelle Kallenberg. So Professor Kallenberg is a professor of internal medicine and dermatology at University of Michigan, where she also serves as the vice chair of research for the Department of Internal Medicine. So I believe it's about 12 years ago that she established her own laboratory and independent research group, and really has spent the last handful or more years in understanding lupus and really trying to utilize her clinical expertise in caring for the patients, but also, to me, this is such a complicated disease. So really spending some time and trying to understand lupus. And again, one thing is that Dr. Michelle Kallenberg is a very experienced and dedicated researcher and clinician, but she's also had several major recognitions from the Lupus Foundation and really a handful of these early and young career scientist awards. So Professor Kallenberg is really, you can say, established in the field of lupus. And I also look very much forward to hearing what you have to say today about the fibroblast in lupus, because that's not always the topic that we talk about when we say cutaneous or systemic lupus. So Professor Kallenberg, while we're just going down to your slides, I really look forward to hearing your talk and hearing what you will tell us today about the fibroblast and how they really matter in cutaneous lupus.
Thank you so much for that introduction. I'm really happy to be here talking about an area that has not gotten a lot of attention in lupus skin disease, and it's been sort of a side project in my lab, but I think we're finding some interesting things. And we don't have all the answers to this question, do fibroblasts matter in cutaneous lupus? But I'm going to throw out some data that we've published and a little bit of unpublished data to sort of spark some dialogue, I think, and interest in this cell population in cutaneous lupus. Here are my disclosures in case you are interested. So cutaneous lupus is an interesting disease. I got interested as a rheumatologist because it's such a frequent manifestation of systemic lupus. And one of the things that I saw in my clinic when I had started practicing rheumatology 15 years ago was that the skin disease in patients could be quite refractory. We could get their nephritis under control with immunosuppression, but their skin would just not cooperate. We do know that Plaquenil is efficacious in about half of patients, but there's, again, a lot of patients that their skin was just very stubborn and hard to treat. And we also know that cutaneous lupus is a really important contributor to low quality of life in patients living with lupus and patients with cutaneous lupus that don't have systemic lupus. And one of the other things that really piqued my interest was that in patients who have systemic disease, when their skin flares, we can often see systemic flares come after. And so things like UV light, which can trigger a lupus rash, can sometimes lead to activation of nephritis or other systemic symptoms. And the other thing that's really nice about cutaneous lupus is that we can study the skin and we can look at triggers of rash like UV light and really have direct access to patient tissue that can help us inform what's going on in the disease. So, as you were told in the intro, cutaneous lupus can be quite complicated, and there are quite a lot of different subtypes of cutaneous lupus. So, I put the three most common up here. So, acute cutaneous lupus, this is typically associated with systemic disease activity. So, you usually don't see this as an isolated disease unto itself. It's usually coming up in patients who have systemic lupus and who have active systemic lupus. This is the classic butterfly rash that comes across the malar prominence of the face. This rash tends to resolve pretty easily with things like steroids, and it doesn't usually leave a scar behind. And it's very photosensitive, so patients can get this malar rash triggered by even very moderate sun exposures, 5 minutes in the Michigan sun, which isn't a lot of sun. Um, and then the second type of rash is this subacute cutaneous lupus. So this can have some pigmentary changes after the rash resolves, but it also doesn't cause a scar. It's typically located on the back, arms, and chest, so you see it more as a truncal rash. It doesn't usually go to the front of the face, and this is also a very photosensitive type of rash, and it's also the most common one that we see from drug-induced lupus, is the SCLE form. And then, of course, chronic cutaneous lupus, also called discoid lupus. This is the most devastating one for patients. This causes scar and scarring alopecia, and it frequently involves the scalp, the neck, the ears, and the face. And so it's really right out there where people can see it. Patients lose their hair. So it can be a very devastating complication of systemic disease, or as a disease unto itself, you can just have discoid lupus. And so it causes patients a lot of misery. It's also photosensitive. We think it can be triggered by UV light, but in the spectrum of photosensitivity, it's thought to be a less photosensitive rash than acute or subacute cutaneous lupus. So, we've published a lot on the role of the skin, and a lot of our work focuses on the fact that keratinocytes in cutaneous lupus are hyperinflammatory, even when the skin doesn't look normal. But one of the things that we also found when we started digging into the cell populations in cutaneous lupus lesions was that the fibroblasts are also very inflammatory appearing. So this was data from 7 cutaneous lupus lesions. 6 of them were from systemic lupus patients, and 1 was from a CLE only patient, and healthy control skin biopsies. And we also had non-lesional skin in these samples. So we took paired non-lesional and lesional. The non-lesional is always from the upper buttock, and our healthy control skin is always from the upper buttock because it's a less sun exposed area than pretty much anywhere else. And so we looked at what the fibroblasts looked like in this single cell RNA sequencing data. And so H is healthy, N is non-lesional, and L is lesional for your reference. And what we saw was that we could see, all the usual fibroblast subtypes, but one of the things that really stood out was that there was this population of fibroblasts, kind of this gold color here, and it was comprised of both non-lesional and lesional fibroblasts, and not a lot of healthy controls. And this was really dominated by a type 1 interferon signature in this fibroblast population. And we had done some spatial sequencing. This is, early days where we're not at single cell resolution, but we had looked to see where these interferon-rich fibroblasts were localizing in skin biopsies of patients. And what we saw was that the interferon fibroblasts tended to be right at the dermal epidermal junction. So they were kind of near where these, abnormal keratinocytes are signaling, and also where some of the inflammatory cells are getting recruited, because most of the pathology in cutaneous lupus is at that interface between the dermis and the epidermis. So they seemed to localize to points of interest in what was happening in cutaneous lupus. And they also were very noisy in their crosstalk. So this is just looking at a cell phone DB analysis of all the predicted receptor ligand interactions that can happen between any cell population in our single cell data. And so we like to do this like global one, not because we can really tell what all these lines are doing, but it really tells us who are the players that are really most chatty and involved in pathology. And what really stood out to us was that these interferon exposed fibroblasts were really doing a lot of crosstalk with some of the critical cell populations that we think are important in cutaneous lupus from the immune side. And this includes a monocyte derived dendritic cell. Here we labeled them CD16 positive dendritic cells. These are coming in lupus, weirdly enough, from non-classical monocytes. And they do a lot of crosstalk with them. We also saw a lot of predicted crosstalk with these PDC-like cells. They don't look like fully differentiated PDCs, but maybe PDCs that have been in an inflammatory environment. So there was also a lot of crosstalk with them. So it looks like these interferon-rich fibroblasts, potentially are interesting. So one of the things we like to do in my work is not just do the single cell, but also try to understand a functional follow-up. And can we really start to trace down like what are the things that are driving some abnormal, appearance of cells and responses of cells as well. And so we took another approach using some funding we had gotten from the Tubman Research Institute here at University of Michigan to try to look at the responses of cells from lupus patients versus healthy control. And so what we did in the first part of this study was we took skin biopsies, non-lesional skin biopsies from patients, and we grew the fibroblasts out of these non-lesional skin biopsies. So we had 34 healthy controls and 22 patients with systemic lupus in this study. And then we grew their fibroblasts out, and then we stimulated them with various cytokines to try to understand how there may be differences in response to inflammatory contexts in lupus versus healthy control fibroblasts. And one of the things that we saw was that there seemed to be this skewing of lupus fibroblasts in terms of their inflammatory responses. And so this is a heat map that shows each of the different cytokines with which we treated the fibroblast populations in culture, and then it shows the response in healthy versus the lupus fibroblasts. And you can see that in general, there's a shift towards a more robust response when we look at what those fibroblasts are making in response to this trigger. And here's just a graphic representation of basically a healthy versus lupus for each of the chemokines and cytokines that the fibroblasts are making. And you can see for most of them, there's a more robust response no matter what we stimulate with in the lupus versus healthy control fibroblasts. And if you average the overall like inflammatory response, you can see that we get about a 7.5-fold difference in effect size versus healthy control when we look at what lupus fibroblasts do in response to stimulation. And so we then got a little bit interested in whether we could start to use this information to help us think about subtypes of cutaneous lupus. And the reason is because we know that the discoid lesions scar. And so clearly their wound healing response is going to be different because the inflammation that's there is not leaving them with perfect skin after the lesion resolves. And so we thought we could start to dig into the subpopulations and think about the fibroblasts because we know that fibroblasts are important both in the wound healing response, but also in, the extracellular matrix and how scars end up looking. And so we then dove into another set of single cell data. It was a larger set. So this included the first single cell patients that we had done, and then we added another 8 patients in. So we had a good number of subacute and discoid patients in the single cell data. And we could see that, the fibroblast populations, some of them seem to be a little bit bigger in the SCLE versus discoid lesions, but the inflammatory fibroblasts or these interferon-rich fibroblasts seem to, roughly be the same in both, maybe a little bit more in SCLE, but we could detect these cells in both of the populations. And again, um, they're showing up here in this gold color, and you can see if we just look at non-lesional versus lesional, you see that you can get lesional SCLE seem to have, a pretty prominent presence in this interferon-rich fibroblast, and then we also saw non-lesional contributions and also some lesional discoid in that population. And so, as I mentioned, discoid lesions are interesting because they really are more pro-inflammatory. You see a lot more immune cells in the discoid lesions when you just look at the pathology, and then they do form these scars. Now, this doesn't look like a scleroderma skin where you get tons of extracellular matrix deposition and tons of collagen, but you can see that there is some scar formation with this deeper blue on this trichrome stain, and more inflammatory nodules around the dermis. So is this like a fibrosis problem? I don't think so. I think this is probably a wound healing problem and how these fibroblasts are responding to the inflammatory trigger. So we dug into that a little bit more, and this is a complicated slide to understand. But what we did was we knew that we had this skewed inflammatory response in our lupus fibroblasts in vitro. And so we thought, well, let's take that signature of what genes tend to be skewed in the lupus response and go back to our single cell data and look at whether we see a more healthy control-like fibroblast response or a more lupus-like fibroblast response when we look at our fibroblast populations through our single cell data and divide them by whether they're coming from a SCLE or a DLE patient. And so what we saw was that when we applied the scores, that in the top here, these are more of the lupus-like score. So if you're behaving more like the lupus fibroblast in vitro, your score would be higher when we apply it to the single cell, what these fibroblast populations are expressing. And what we saw, so red is the SCLE and blue is the DLE, that overall the DLE fibroblasts in the single cell data had more of this like skewed lupus inflammatory response than what we saw in the SCLE. And when we took the control signature and applied it, we saw that the fibroblasts from the SCLE like patients had more of a control like signature, suggesting that maybe they have more of a paradigm of wound healing without scarring versus what we see in the discoid patients. And then we use some pseudotime analysis to see where these inflammatory cells are deriving from, like which fibroblast populations are giving rise. And so on the pseudotime, they kind of plop right here in the middle. And you can see that, they really are kind of on the end of the pseudotime. And if we map it out, you can see that the inflammatory fibroblasts, which are in this salmon color here, kind of run into what we see of the ApoE positive fibroblast population. And so that's kind of interesting because ApoE positive fibroblasts, there's been some studies that show that they play a role in fibrosis and inflammatory skin lesions. And so they seem to kind of be, the ApoE can sort of modulate wound healing. And so maybe this is something that should be looked into further in terms of like where these fibroblasts derive and how the ApoE might be affecting their behavior. So we looked at these inflammatory fibroblasts from our single cell data, and we also used upstream regulator analysis to see if we could identify what are the signals coming into those fibroblasts that are really sort of skewing their inflammatory profile. And so this is, a predictive tool from IPA. And what you can see is that we get things like TNF, interferons, type 3 interferons, TGF beta. So, there was a lot of these like usual players that seem to be playing a role in sort of changing this profile. And it's not just interferons, right? There's other inflammatory stuff that looks like it's sort of skewing this response in this, signature. So lucky for us, we when we just, sometimes things just work out and you're happy when like all the stars align, because when we had done this study, all of these upstream regulators that we pulled out of the single cell data to sort of look at these inflammatory fibroblasts, we had used these in our in vitro study. This wasn't intentional, it was lucky, but sometimes it's better to be lucky than good. So what we did then was we went back to our data and we said, well, let's take all these lupus patients and divide them on whether they developed scarring, because all these patients had cutaneous lupus, right? So whether they had developed scarring lesions from their lupus or whether they had non-scarring lesions from their lupus. So whether they were DLE or some other type of cutaneous lupus that didn't form a scar. And we judged this based on their Class C damage scores. So they had to have a score of 1 or less in order to be the non-scarring group. So we had 8 patients from the original fibroblasts that we looked at that had scarring skin lesions. And so then we went back and just looked at the bulk RNA-seq data again. And we divided them by whether they were non-scarring or scarring, and then again looked at their cytokine responses. And what we saw was that there was actually a higher trend for some of these inflammatory responses in the non-scarring fibroblasts. And what we saw that came out in the ones that scarred was actually some skewing of their collagen pathways. So this was really interesting because, you know, it seems that even though like the lupus signature is inflammatory, when you look at individuals who scar versus don't, when you treat their fibroblasts with individual cytokines, what you see is that you kind of push towards a collagen production pathway in the discoid patients, whereas the subacute seems to have a more inflammatory response, and that may be more beneficial to like organized wound healing. So this is, you know, it's hypothesis generating still, like we don't know exactly which of these things are important, but I think it's a really cool observation that we can see this skewing towards dysfunctional wound repair and collagen production in the discoid fibroblasts. And so I'll just show you one last piece of data. We now have been digging hard into our single cell data, comparing healthy control versus, we've got healthy control populations, but we're really digging into DLE versus SCLE on a single cell level, and like, what are the things that we see? And this is a cell chat analysis, just looking at things. So this is looking at basically predicted upstream signals that are coming in to all the different cell populations in discoid skin lesions versus subacute cutaneous skin lesions. And so all the cell populations that are receiving signal are listed across the bottom, and then the predicted signals are listed across the top. And then on the left here are the discoid patients, and on the right are those that are SCLE lesions that we had biopsied. And there's some really interesting things that are starting to pop out, and we're still in the middle of the analysis of this data. But one of the things that I thought was kind of interesting was that TGF beta as an upstream signal really only seemed to be affecting keratinocytes, whereas in SCLE, we see more of this signal coming into some of the inflammatory cell population. So maybe TGF beta isn't like a super important regulator of what's happening in the skin, at least at this with the ones that we've sampled here. But what we do see is there's things like MIF, which are strikingly different as a predicted upstream regulator in DLE versus SCLE. So you can see here, all the fibroblasts are over here on the left. So in terms of what's signaling to the fibroblasts in discoid, there's a very strong predicted signal coming from MIF, but we really don't see that in SCLE at all. And the same for other things like prostaglandins. There seems to be a strong incoming signal to fibroblasts from prostaglandins, but it's completely missing in the SCLE lesions. So, you know, this type of analysis, I think, is going to identify additional factors that we need to dig into in terms of what is sort of driving like unique discoid pathophys. So we're doing that. We're you know, still working on analysis. It takes a long time to get through single cell data, but I think there's potential here for some really interesting findings in terms of what is modulating fibroblast function in these two different disease subtypes. And so we're working on that. We've also done a bunch of work with wound healing studies, and we're putting a paper together now. We see some differences in how fibroblasts are able to like close a wound and respond to wound healing assays in the presence of inflammatory cytokines between discoid and SCLE patients. And then we're also very interested in the role of STING activation, as we see a very strong STING phospho-STING upregulation in lesional skin in the fibroblast populations in lupus. So what STING is doing and how that's modulating their function, I think, is another interesting question. And then we're certainly digging into this more about these critical interactions that are sort of like driving fibroblasts to do what they do. And then again, how do drugs that we currently have available for lupus, we're doing some pre and post treatment studies by single cell and ATAC-seq to see how these drugs are modulating cellular phenotype. And so that is ongoing. And then, one of the things we really don't know is whether fibroblasts are participating in triggering of disease lesions. We have a paper under revision right now where we've studied UV treatment of the skin of lupus patients and then biopsied their minimal erythema dose site 24 hours after we treat them with UV. And fibroblasts are really talking loudly to a lot of the myeloid populations in the lupus skin when we look at sort of like cell chat type of analysis after UV exposure. So what are fibroblasts doing in that UV response? They're obviously probably not getting the direct signal because most of the UVB is stopping in the epidermis, but probably the keratinocytes are talking to the fibroblasts, and the fibroblasts are like inviting everybody else to the party. That's kind of how I think about what's happening. And then again, there's a lot of interesting data too about the role of extracellular matrix as a modulator of inflammatory function. And there's also questions of whether the ECM might be getting messed up in cutaneous lupus. There's a ton of mucin production and other things hanging around. Does any of that modulate how the extracellular matrix is talking to the immune cells themselves? So I think that's a completely unknown question in cutaneous lupus, but I think may also be important to think about, and certainly things that we're planning on digging into. So with that, I just want to thank a ton of people in my lab and people who previously worked with me that have helped us with our studies, especially Johanka Johnson in dermatology here. He's a fantastic partner to do research with. And then obviously the Taubman Institute, which gave us funding for a lot of these patient samples. And of course, our patients at the University of Michigan. We couldn't do anything without their skin samples, and we're very grateful to everything that they have helped us achieve. So thanks a lot.
Great. Thank you so much, Professor Kallenberg, for helping us understand a little bit more of this complicated disease. So coming from dermatology myself, I think keratinocytes are the most important cell type, but I know that many people in the extracellular matrix community just love fibroblasts. So I'm sure that many of these have appreciated your talk, and I can also see questions coming in. So before we move to the Q&A session, we have the last speaker for today's program, and that is Dr. Christina Mertz-Stückle. So she has worked with autoimmune diseases for the past 25 years. The majority of her scientific career has been in the pharmaceutical industry. So during her, you can say, scientific and academic life, she studied at the University of Oxford and Tübingen, where inflammation, autoimmunity, and caring about the patients that are really suffering from those conditions has always been close to her heart. But the past handful of years, she's been in the pharmaceutical industry, as I mentioned, where she's developed some of the drugs that we have in our clinics today, and also still continuing trying to develop drugs that we can use tomorrow. So she's currently working as a senior principal scientist at Novartis in Basel, and really, again, trying to bridge from early preclinical studies onto clinical science and also drug development. So today, Dr. Mertz-Stückle will speak about the challenges in drug development and particularly in systemic sclerosis. And again, after her talk, we're going to bring all the speakers back online on the stage where we can discuss all the good questions you have been asking in the chat.
Welcome, everyone. I would like to start by thanking the organizers for inviting me to speak at this webinar. Unfortunately, I cannot attend live today, so we pre-recorded the session. However, if you do have questions, feel free to reach out to me. I'm more than happy to follow up via email. So these are my disclosures. Thinking back to the first systemic sclerosis conference that I attended, there was actually one remark that got stuck in my mind. One of the speakers said that no drug has been proven to be totally inefficacious until tried in systemic sclerosis. So now, luckily, this is not quite so true anymore, but developing a drug for systemic sclerosis is still a major challenge. And today I would like to walk you through some of the major issues that complicate drug development for systemic sclerosis beyond those that are faced by any drug development program. But before I come to that, I would like to give a short introduction about systemic sclerosis. So systemic sclerosis is one of many chronic and often progressive autoimmune diseases. What is special about systemic sclerosis is that it's characterized by this triad of vasculopathy, inflammation, and autoimmunity, as well as fibrosis. One of the cardinal features of the disease is skin fibrosis, but it's a systemic disease affecting various internal organs as well. These other organs include the lung, the GI tract, and the heart. Fibrosis of the skin impacts patients' ability to move or bend their fingers or open the mouth, for example. And fibrosis of internal organs affects organ function and can lead to organ failure, overall contributing to significant morbidity and unfortunately even mortality. Lung fibrosis or interstitial lung disease really has a major contribution here. And beyond these organic manifestations, patients often may experience depression and fatigue. Currently, unfortunately, there is a lack of really effective disease-modifying drugs. Patients are generally treated with immunosuppression, but this has limited efficacy. There are also some treatments available for some of the symptoms and complications of the disease, for example, ACE inhibitors to treat systemic sclerosis renal crisis. More recently, the antifibrotic drug Dintendadib, a multityrosine kinase inhibitor, and tocilizumab, an IL-6 receptor blocking antibody, have been approved for the treatment of systemic sclerosis-associated interstitial lung disease. They can slow down lung function decline. Hematopoietic stem cell transplantation can also be considered for severe and very rapidly progressive patients, but this procedure is not without risk for the patients. More recently, first case reports of patients that have been treated with CAR T cells or T cell engagers to deplete B cells were published, and they look quite promising. Nevertheless, there's still a remaining high unmet medical need in this indication. So coming back to drug development, drug discovery and development in my mind is always a bit like climbing a mountain. You start somewhere at the bottom and you'll try to figure out a route that brings you up to the summit. So on the way there, you might need to put in some hooks and install some ropes, or you might be able to use hooks and ropes that other people have already installed to help you up to the top. So obviously some mountains are steeper and less well known, but others are much more traveled and much more explored. And some parts of the climb are easier and others can be very challenging. So I think that drug development for systemic sclerosis is a bit like trying to climb the Eiger North face that you see on the picture. The Eiger is actually a famous mountain in Switzerland where I live, and it's been considered for a long time to be unclimbable, but until about 100 years ago when the first group managed to get up there. So these days it's being climbed much more regularly, but it's still a risky endeavor, and frequently climbers fail and need to be rescued. But others make it to the top. So with drug development for systemic sclerosis, it's a bit like this. It seems doable these days, but it's not easy, and we have to rely on some of the hooks and ropes that others have installed to help us with the most difficult parts of the climb. One of the first challenges that comes to mind when thinking about drug development for systemic sclerosis is the complex disease pathophysiology, which is still not fully understood. Other points that also make things more complicated include disease heterogeneity, the lack of translatable preclinical models or predictive or prognostic biomarkers, and finally also the difficulties of assessing therapeutic effects with meaningful and validated clinical endpoints. So let's start with the complex pathophysiology. I've already mentioned vasculopathy is an important component of the disease, as well as inflammation, autoimmunity, and fibrosis. There are certainly multiple mechanisms that play a role, but how much and to what degree they actually contribute to the disease and the various manifestations is still not fully understood. An early event during the pathogenesis appears to be vascular injury that is associated with immune cell infiltration. Raynaud's phenomenon, this is blanching of the fingers when exposed, for example, to cold, is one of the first signs of the disease. It's caused by aberrant constriction of the blood vessels and leads to local hypoxia. However, this is not specific to systemic sclerosis, and it can also precede development of other autoimmune diseases. Often it can also occur all by itself and can also disappear spontaneously. But the other way around, nearly all systemic sclerosis patients have Raynaud's phenomenon, suggesting that vasculopathy really contributes to disease pathogenesis. The immune system also plays a role. Autoantibodies are very common. These include antinuclear antibodies, which are not specific for systemic sclerosis, as well as disease-specific autoantibodies, such as anti-topoisomerase antibodies, that may play a role in the diagnosis of systemic sclerosis. But to what degree they're only associated with the disease, and what degree and by what mechanism they actually contribute to systemic sclerosis, is also something that is not fully understood. The positive outcome of a study with rituximab, a B-cell depleting antibody in Japan, has raised a lot of interest in the role of B cells in the disease, and also what role they might play beyond autoantibody production. Interferon signaling, macrophages, and other myeloid cells also play a role, but many of these mechanisms are also active in a number of other autoimmune diseases. And so how this leads to the specific manifestations and the prominent fibrosis in systemic sclerosis is an area of active research. With regard to the third component, fibrosis, we know a lot about the pathways that may drive fibrosis, such as TGF-beta, Wnt, Hippo signaling, EGFR signaling, and of course extracellular matrix synthesis, and these would be attractive to target. However, these pathways typically also have roles in normal physiology, which can make them very challenging to modulate therapeutically because of the associated toxicities. The anti-TGF-beta antibody frisolimumab has been tested, for example, in systemic sclerosis. And patients treated with the antibody experience a rapid improvement in skin fibrosis, but also bleeding and anemia. Inhibitors of EGFR signaling are approved for treatment of specific cancers, but they frequently cause skin toxicities. In addition, to make things even more complicated, fibrosis can become independent of the initial trigger. Luckily, there's been massive progress in understanding complex pathophysiology in recent years. I think we are getting a much better picture of the processes that underlie the disease through the development of omics technologies. For example, there have been a couple of single-cell datasets published in the last couple of years, which allowed, for example, the identification of different fibroblast subsets and helped to get a better idea of the potential interactions between stromal cells and immune cells that might drive the disease. The advent of spatial technologies may potentially offer even more granular insights into these topics. On the other hand, we still have a lot of open questions, and I can't list all of them here. One thing is that because many of the technologies that have been used to assess disease tissue are RNA-based, the composition and the role of the extracellular matrix is often not looked at and therefore possibly underestimated. We also don't know too much about organ-specific drivers of fibrosis, and why in some patients a certain organ is affected and in others not. And furthermore, while the vast majority of scleroderma patients experience GI tract involvement, and there would be a clear unmet medical need there, this is an area which is still clearly understudied. Another thing that can make drug development quite challenging is the disease heterogeneity in systemic sclerosis. So this is certainly a challenge for clinical trial design, but it's also a challenge for research. Patients differ with regard to the extent and progression of skin fibrosis. So if only the distal extremities, head and neck, are affected by skin fibrosis, these patients are classified as having limited disease. If the fibrosis is more widespread, affecting the upper arms and legs or the trunk, they are considered to have diffuse disease, which tends to be more severe and comes with more internal organ involvement. Skin thickening is assessed by the modified rotten skin score, where an investigator assesses the hardening of the skin by pinching in defined locations and giving a score from 0 to 3, depending on how well the skin can be pinched. This is then added up over the whole body. Progression of skin fibrosis can actually differ significantly between patients, and here you see typical trajectories, with some patients progressing rapidly and stabilizing after a while in many cases rapid progression can be followed by a partial improvement. In other patients, progression is slower and the extent of skin fibrosis peaks at a much lower level. You can imagine that over the duration of a clinical trial, this natural course of the disease means that often there will be improvements in the placebo group, which need to be taken into account. You can also imagine that if you recruit more patients with the high baseline improver group into one arm of the trial than in the other, you risk that the effect that you see is not actually due to the treatment. Or the other way around, that the effect of the drug appears to be weaker than it actually is because the placebo group is biased towards improvers. So this risk is bigger the smaller the trial is. Beyond the severity and trajectory of skin fibrosis, there are also other aspects in which the disease is heterogeneous. While the skin and the GI tract are involved in the majority of patients, clinically relevant interstitial lung disease does not occur in all patients. Lung involvement is associated with a more severe disease, for example. Cardiac fibrosis is also found in some patients. In addition, differences in occurrence and severity of other manifestations such as Raynaud's phenomenon, pulmonary arterial hypertension, digital ulcers, and calcinosis also contribute to disease heterogeneity and can complicate clinical trial design. This means that in order to demonstrate efficacy, patients will need to be stratified. So this is of course not ideal since systemic sclerosis is already a rare disease, and by stratifying you further limit the number of patients. Advances in clinical and molecular profiling have already helped to enrich for patients who are more likely to progress or maybe more likely to respond to a treatment, but there's still a lot of opportunity here. And given the disease heterogeneity, this can also mean that maybe only a subset of patients may have a response or a statistically significant response to a drug. I think a good example is the phase 3 trial of tocilizumab in systemic sclerosis, and the study failed to meet its primary endpoint, a statistically significant improvement in the MRSS score, but it did show a positive effect on lung function in patients that had ILD. So overall, reliable prediction methods to forecast disease progression at an individual patient level would really increase the chances of clinical success and help to select patients that are more likely to benefit. So let's assume that despite the complex pathophysiology and the disease heterogeneity, you've identified a mode of action that could potentially be used to treat scleroderma patients. The next step to climb would be to test this mode of action in preclinical models. Medium throughput preclinical models can be, for example, primary cells such as skin and lung fibroblasts, or immune cells isolated from peripheral blood, depending on your mode of action, or endothelial cells. These tests can be very informative. However, it's important to keep in mind that patient-derived cells might behave differently than their healthy counterparts, and access to patient-derived cells can be limited. There are also various animal models of systemic sclerosis, such as the bleomycin-induced skin or lung fibrosis model, or the topoisomerase 1 model, or GVHD, in which fibrosis is induced, or the tight skin model and the FRA2 transgenic model, which are genetic models. But they all have in common that they don't really recapitulate all aspects of systemic sclerosis pathology. So these animal models can be very useful to demonstrate pathway modulation in vivo and to assess PK-PD relationship. Of course, this requires that your pathway of interest is active in this specific animal model. So they can be very informative, but one needs to keep in mind that they have limited translatability. I think the bleomycin model is a good example here. It's one of the most commonly used models, and in this model, skin fibrosis can be induced by repeated injection of bleomycin into the skin, or lung fibrosis by intratracheal instillation of bleomycin. So bleomycin leads to a robust inflammation, followed by fibrosis that is often self-resolving. However, there's no vasculopathy in this model, and the autoimmune component is also missing. Various compounds have shown efficacy in this model, but they failed in the clinic. On the other hand, treatments that are showing some promise in the clinic have shown little or no effect in this model. So yes, in vivo models can be informative, but they are not necessarily predictive for clinical success. One way to potentially get additional confidence would be patient-derived complex models. So this is something that has emerged in the more recent past, and I think this is a very interesting development. These patient-derived complex models are not only of interest for systemic sclerosis, of course, but for many other diseases as well. In the case of systemic sclerosis, for example, precision-cut skin slices or skin cultures or organotypic models of skin and potentially lung could help to understand the effect that a potential drug may have on patients. Of course, these models also come with their own limitations. So one of these is that the tested compounds need to modulate the respective pathway rather quickly, because especially tissue slices do not survive endlessly in culture. Another limitation is that the target cell of interest needs to be present in the chosen system, because otherwise you won't see an effect. And some mechanisms, such as modulation of immune cell recruitment, for example, cannot be assessed at all in these in vitro systems. Nevertheless, these models offer a lot of value and may be as close to patients as possible. So once again, let's assume that you do have all the preclinical data that suggest your drug might actually help patients. Then there's another step to climb. What biomarkers could help you to select the appropriate patients? What biomarkers can help you decide if your drug is doing what you hope that it's doing on a molecular pathway level? And what biomarkers can help you to assess efficacy, ideally early on? Now, biomarkers in the field of fibrosis in general and systemic sclerosis in particular are a significant challenge. I think circulating biomarkers to assess fibrosis or disease progression, such as extracellular matrix peptides or other type of markers, are mainly exploratory at this point in time. Autoantibodies have some prognostic value, and some organ-specific biomarkers such as KL6 for ILD severity exist, but overall there's still a lot of opportunity here, especially for biomarkers that allow monitoring of therapeutic benefit. Another complication is that fibrosis affects several organs and tissues, so you don't necessarily know which organ you're actually monitoring when using soluble biomarkers to assess fibrosis. Profiling of tissue biopsies can help to understand the mode of action at tissue level, but are typically only used as exploratory endpoints in clinical trials. But nevertheless, they can be very informative. More recently, imaging biomarkers have been explored and developed, and these can be very helpful to assess disease progression. High-resolution CT scans can be used to better assess lung involvement, for example. Ultrasound technologies are being investigated to quantify skin thickness and elasticity, but they also require further validation. New developments also include PET-CT or MRI imaging techniques with tracers to track specific cells or cellular processes. FAPI imaging is such an example. FAPI PET tracers mark activated fibroblasts that are indicators of active inflammation and/or of fibrosis. I think these look very promising because they allow non-invasive monitoring of disease progression or disease progression in certain organs to help assess the physical manifestations of the disease. One limitation for using those readouts in clinical trials is that they require the respective infrastructure and trained investigators to be present at the site. So finally, demonstrating meaningful disease modification by a drug in such a way that allows approval is another challenge for various reasons. And I think one important one here is the endpoints that are currently accepted by the health authorities. For systemic sclerosis, these are essentially the modified rotten skin score, and for scleroderma ILD, forced vital capacity, a measure of lung function. While with good training, an observer can score MRSS quite reliably, there's still significant inter-observer variability. Another limitation of this readout that I've already mentioned is that frequently it spontaneously improves over time, meaning that this is typically seen in the placebo group as well. Newer, potentially more objective technologies, such as quantifying skin thickness by ultrasound, are under investigation but are not validated. For lung fibrosis, FVC lung function test is used as the readout, and a decline in FVC is considered a surrogate for survival. Limitations of both of these endpoints are that trial periods of minimum 24 weeks, but typically more like 52 weeks are required to really see meaningful differences. So readouts that could detect changes faster would be extremely helpful. As I've pointed out earlier, not only skin and lung are affected by systemic sclerosis, but other organs such as the GI tract are prominently involved as well. So currently we are lacking ways to comprehensively assess, for example, this specific aspect of the disease, although it has a major impact on the quality of life of many patients. Importantly, there is efforts ongoing to establish composite endpoints, such as the revised CRIS score, as endpoints accepted by the health authorities. The revised CRIS score include measures beyond MRSS and lung function, such as physician global assessment, patient-reported outcome or patient global assessment, and disability scores. The Euster Activity Index is another way to capture disease activity, including MRSS, patient-reported worsening of skin fibrosis, digital ulcers, and tendon friction rubs. So these provide more sophisticated readouts that better capture disease activity and heterogeneity than just relying on the MRSS. It takes a lot of effort, though, to validate new endpoints before they're accepted by health authorities. Finally, coming back to the image of climbing the Eiger North face, I think significant challenges remain in various areas, including complex disease pathology, disease heterogeneity, translatable preclinical models, biomarkers, and clinical endpoints, but also significant progress has been made in the last years in all of these areas. I think more climbing hooks and fixed ropes have been put into place or are being put into place, that have made the path up the mountain of systemic sclerosis drug discovery more climbable. And hopefully we'll see more drugs making it to the top, helping patients and improving their lives. Thank you very much for your attention. Unfortunately, as I said, I can't answer any questions live, but please do reach out to me in case of questions, and my email address is at the bottom of the slides. Thank you very much and have a wonderful rest of the day. Bye.
Great. Thank you so much to Dr. Stolke. I really appreciate, or Matt Stolke, I really appreciate you recording this video, even though you had a conflict of interest at this time. So with this, I would like to invite our speakers back on the stage to address some of the good questions you added to the Q&A session. I appreciate the ongoing chat. I think that's really great that you could discuss some of the immune cells and inflammatory fibroblasts. We always like these type of discussions. But if I should start with one of the first questions that was addressed by Ahmed, and that was to Professor Khanna, saying, have you identified any biomarkers in SSC that you would recommend, and particularly SSC-ILD at this stage to look into, you can say, the skin and lung fibrosis? So I can see Dr. Khanna you're on mute.
Well, I'm here. I don't know what happened to my camera. My camera is on, but it is looking at something, not at me, for sure. I'm trying to figure that out. Okay, so the question is regarding ILD and IPF, and I think there are biomarkers of the patients at risk of ILD. For scleroderma ILD, I can talk about, which are autoantibodies such as topoisomerase antibodies and acute phase reactant. I showed you with the tocilizumab program that patients who had elevated acute phase reactant were more likely to develop progressive ILD. And of course, there's SPD, which is a marker of alveolar injury, SPD, which I showed you as part of tocilizumab, a marker of epithelial injury. So there are biomarkers, they overlap, but also differentiate from IPF, which is predominantly a fibrotic disease, whereas early ILD, again, the way I put it is an interplay between inflammation and fibrosis.
Yeah, great. Yeah, I completely agree. So we still, as our Christina just said, basically that there's still a way to go to really get these established biomarkers, but there are quite some good ones on the way. So if we continue a little bit with the scleroderma, Stefan says, lovely talk, and I agree with that, Dr. Khanna. And then he says, where does rituximab fit into the treatment pathways for SSC? And do you think there's still a role for the IL-1, so alpha and beta antibodies, particularly in addressing cardiac outcomes?
So I can't figure out, I'm standing in front of the camera sitting, but I can't see myself. So this is a unique challenge. So talking to the role of rituximab, I think the last talk was very fascinating and interesting, just to hear a perspective from a major drug developer such as Novartis, talking about the challenges, and all those challenges are real in systemic sclerosis, likely in lupus. I think part of the challenges we have is that the understanding the pathogenesis and interplay between inflammation and fibrosis have somewhat been elusive. B-cell targeting with rituximab has been somewhat effective, but nothing remarkable effectiveness out there. But when you look at our data that will be presented at American College of Rheumatology with the CAR-T targeting autologous CD19 and some of the unpublished data, targeting B cells definitely seems to be effective. Again, I want to highlight that's an earlier diffuse scleroderma subset or those with progressive ILD. There's a lack of data, again, showing our bulk RNA-seq data. The activated B cells or T cells later in the disease, if you go beyond 5 to 6 years, is rather small, that proportion, and I'm not sure how effective these therapies would be. So rituximab, I'm not sure, but a deep depletion with Novartis. Actually, Novartis has 2 ongoing trials that I'm leading. One is a CAR-T targeting autologous B cell, and number 2 is a drug called ianalumab that is a BAFF receptor inhibitor and also targeting the recirculating B cells in the blood. IL-1A and IL-1B, I'm not sure the drug that really works for cardiac involvement in systemic sclerosis is tocilizumab. If you go back to the clinical trials of tocilizumab, there was a disproportionate AEs and SAEs with cardiac involvement in placebo compared to tocilizumab, and there are case series and our unpublished data in patients with active myocarditis with systemic sclerosis. The go-to target is IL-6 inhibition.
Great. Thank you. So you almost spoke into one of the next questions that is actually for the both of you, because this CAR T cell is very hot in almost all autoimmune diseases. So we can start with you, Professor Kallenberg. So how do you see CAR T cells in lupus? Will it be the perfect treatment in 5 years, or how do you see it for your maybe both systemic and cutaneous lupus patients?
Yeah, it's a good question. You know, so far the CAR T studies that have been published, they haven't given a ton of like individual organ manifestation data, and the most of the current ones are targeting lupus nephritis. When you dig into like the larger case reports that Schott has published in lupus, what you see is that everybody's SLEDAI went to 0, and some of those patients had points for cutaneous disease as part of their initial SLEDAI. Now, whether it was an ACLE rash that tends to go away no matter what, or these were discoid patients, I think we don't know. But everything got better in those studies, right? So I think potentially it could be helping. I think the data for B cells in cutaneous lupus has been very confusing because Benlysta, belimumab, we use it, and we used it quite a bit in cutaneous lupus when we didn't have anything else on board. It's hit or miss. Like I would say some patients it actually does help their skin, and some patients it does not. And so we have an ongoing project kind of looking at pre and post drug treatments to try to understand, what's happening. And we were looking yesterday at one of our patients who was a Benlysta responder with her discoid lesions, and we definitely saw, she had B cells in her skin. We got to dig into like what subtypes those B cells are, but she did get better with belimumab treatment. So how that will translate to CAR T, I think the jury is still out. And whether CLE alone would ever be considered serious enough to warrant trials with CAR T therapy, I think is another question, right? These are not easy studies to put patients through. They're they're long. You have to like be in the hospital, you leave your family, you're getting immunodepleted for most of these, and then then there's risks of like really whacking your B cells down. So I think there'll be a risk benefit calculator that eventually comes out if we do see success with CAR Ts. Like, what are the right patients to put into that treatment pipeline, and which patients we can treat effectively with other drugs, without having to go all the way to CAR T. So I think there's a lot to be learned yet. But yeah, I think there's potential that at least for some patients it could be effective, but we'll see.
That's great, Dinesh. Now that we have you back on the camera, do you have any perspectives on CAR T in systemic sclerosis?
Yeah, I think the cellular therapy, what we heard in the last lecture was the difficulty in targeting systemic sclerosis, the challenges in understanding the pathobiology, and the challenges with the natural regression of the skin and improvement of the patient function and feel. Our experience, we have done 13 patients so far at University of Michigan. As part of clinical trials. We have done both CAR T and allogeneic CAR NK, all have been targeting CD19. My initial feel and the data that will be presented at ACR is that for a small subset, it seems to be extremely effective. Remember, these are patients for cutaneous lupus, for systemic lupus, there are approved therapies, and Michelle does a much better job managing those patients than I do. My scleroderma patients, but our patients are with a high unmet need, high morbidity and mortality. So I definitely see a venue out here that for a subset of patients, this therapy is highly effective. We have shown, and others have shown, there's a complete depletion of B cells, both at the protein and a gene level in the lymph node tissue, at least for at least a year or so. And the cells that are coming back, B cells, similar to lupus, are healthy, naive, and transitional B cells that are coming back. So all that works. The skin is improving, the lung functions have improved in patients who had progressive ILD. So you've changed the trajectory of the lung function. There are many questions, like Dr. Kallenberg said. Number one, the feasibility of it, especially in real practice. And number two, whether the remission is sustained and whether the remission will translate into cure. If there is one cure for scleroderma or systemic sclerosis right now, that is autologous myeloablative stem cell transplantation. Not in every patient, but we have patients over 15, 20 years now who have been in sustained remission due to their progressive internal organ and skin disease. So we all are very excited, but there are many questions that we must answer. But at least in scleroderma, I see a hope of remission, a hope for long-term treatment, free cure, remission, whatever you want to call it, and time will tell how long does it last.
No, thank you so much for that. Yeah, because I think the question that was asked was a bit prerogative, whether we would just do it in 5 years. And I think you're both very right that we need to find the right patients. Otherwise, there's probably going to be some side effects that are not helping your disease.
There are side effects, and there are key side effects. And for our audience, I want to highlight, we have seen ICANS, we have seen CRS, we have seen prolonged neutropenia. There are some patients with the B cells in the periphery have not come back after months and months. So there are real significant side effects that are associated. And most of them are phase 1 studies. That's also to highlight. There are a couple of phase 2 trials that are starting. They are safety trials, and they should be treated as safety studies right now.
Yeah, I will say I just saw some really interesting data, like in this vein, just thinking about like what we don't understand about the long-term consequences there. So there's a investigator named Ankur Singh who's at Georgia Tech, and he's been able to generate these artificial lymph nodes using PBMCs from patients, and he can really reconstruct these artificial lymph nodes quite well, including germinal center formation and all sorts of things. It's really quite impressive. And he's been studying patients just with lymphoma and leukemia who've been getting rituximab treatment. And what he showed was that when you look at like vaccine responses and things down the road from this B cell depletion, there are some patients who don't regain the ability to have good vaccine responses after, R-CHOP, for example. And what he's showing in his artificial lymph nodes is that you get zero germinal center reformation. And so, depending on which B cells you deplete, you might lose your ability to sort of recreate these necessary lymphoid structures for, maturation of your immune system. So I think there's a lot of things that need to be studied in these patients too, like post-treatment, like how normal do their immune systems become just because the naive cells are there. And what he showed was like the naive cells come back in everybody, but it's only the ones that like lose their antibody functionality. They don't get good germinal center reformation. There was really good concordance between his artificial lymph node data and what you see in patients with vaccine responses. So I think, these types of approaches will be really important to study as well, so that we really can understand the long-term consequences of these types of things.
Yes, we need to understand that we're still quite early phase, even though some are moving into phase 2A, but we are still early days for this treatment.
And we should also, I was just going to add, we should also work with you, Nordic and others, trying to look at the collagen production and degradation neoepitopes. Most of the trials that we have done, tocilizumab and autotaxin inhibitor, the impact really has been on the degradation biomarkers, and that's not what I would have anticipated. I would have anticipated that the collagen production, whether it's collagen 3, 4, 6, would have been modulated, but that's not what we are seeing. So it would be interesting to see what CAR-T patients, by really disrupting the B cell biology, what impact and how does it impact the collagen production and degradation and overall extracellular matrix biology and deposition.
Yeah, and I'm sure we could continue this talk, but we're already a little bit over time. So I think I need to stop now. I just want to highlight real quickly that, first of all, thank you to all your speakers. I really enjoyed it. I think it was a lot of fun, and you gave some good insights into, to me, complicated diseases, heterogeneous diseases. So we really need to find the right patients for the right treatments. And then to everyone who is listening, I hope to see many of you at the Extracellular Matrix Pharmacology Congress in Copenhagen in June next year. And with that, I hope you have a great rest of the day or a great evening. Thank you very much.
Bye, everybody.
Bye.